Hello, dear students and esteemed learners. Welcome back. Welcome to my course on Sociology of Health. The topic for today's lecture is Addressing Health Inequality in India, Trends and Initiatives. Now, this is the 12th week of our course, and this week we have identified the theme Health Inequality and Sociology of Health. So, in the previous lecture, we tried to understand what do we mean by health inequality. And there we tried to understand that health inequalities are basically that kind of differences in health outcome which persist at the level of the groups, and these differences could be reduced, mitigated by appropriate policy interventions, and so these inequalities are also identified as inequities, health inequities. We try to understand the perspectives which are basically given at global level or academic level. Now we will try to see what is happening in Indian context. And in this lecture, I've tried to include important points or concepts which are like health inequality and inequity, then 4 forms of health inequalities in Indian context, then structural inequalities in India, then privatization of healthcare, and then why health inequalities and inequities prevail in India and what is the way forward, right? How can we address the problems related to the emerging health inequalities? So all these things we will discuss in this lecture. And yes, you may remember in many of the previous lectures we have been talking about the inequalities and disparities which are existing at different levels within the healthcare outcome of people. So we will refer to all those so that at this point of time you can have a larger view, a comprehensive view, a comprehensive understanding about what is health inequality and what kind of inequality is existing at which level and what are the interventions required to address these at a larger level. Now, when we talk about Indian society, then as a student of sociology, we get to know that in India, there are multiple types of inequalities and deprivations exist historically. When we were studying sociology at very elementary level, we were studying the concept of stratification and differentiation. And stratification actually talks about the division of society in multiple strata. India is not the only country which is basically witnessing the issues like stratification. World over, societies are stratified because historically this process of stratification continued to exist. So, when we try to understand the issues related to inequalities in Indian context, we get to know that there are gender-based inequalities and then caste-based inequalities persisting from a very long period of time. And then, of course, the income-based inequalities are very much there globally. In the rest of the world, we find the racial inequalities also prevailing. For many sociologists and other thinkers, the racial inequalities are not existing in India because race is not identified or considered as a major identity in India, but there are basically caste related and sometimes even the ethnic identity related inequalities are existing. Then there are 2-3 other important things. One is this, that the spatial inequality is very visible in India. India is having multiple states, 29 as of now. And if we try to understand the socio-economic development processes in all these states, then we get to know that there is kind of disparity or inequality existing in terms of the various states. That is one point. And then the rural-urban divide is very much here. The rural-urban divide is also getting reflected at the level of the states, at the level of the regions, and almost at every level. So there are multiple inequalities that we can identify as a student of sociology and social science in India. Now, cutting across these inequalities, which are often identified as a structural inequality because these are inherent within the structure of Indian society, there is emergence of a new form of inequality, that is actually health inequality. And health inequality is largely considered as a contemporary phenomenon. Now, it is very difficult to say whether this is a contemporary phenomenon or it has also existed earlier, because we are not having the specific data related to this. And another important thing is this, that health institutions are basically the institutions which developed in contemporary context only, right? So prior to 20th century, we were not having the systems of medicine which we are having as of now, and so the people at large were not having access to or reach of these systems of medicine, and so there was a larger segment of the society which was deprived of these kind of facilities, because the system of medicine itself was almost not available the way it is available as of now. Although we had the traditional systems of medicine, and we have been saying that in every society some system of medicine has always been there, because medicine is actually a socio-cultural phenomenon also. However, the kind of disparity and inequality that we are talking about, that is more getting associated with the modern system of medicine, because here we find the larger organization of medicine and organization of health system, right? So we are talking about actually the modern health institution, and that is why we are saying that the health inequality is actually emerging in contemporary Indian context. And the divide between rich and poor is very much visible, and then the disparities existing at a regional or a state level are also visible. And then of course the divide between male and female, when we talk about gender inequality, that is also visible, and we are trying to understand these things. So with this much of understanding, one thing is very obvious or clear by now, that when we talk about health inequalities, then primarily we are talking about the health outcome at the level of the group and not at the level of the individual. So we are not talking about the person to person health differences, rather we are talking about the differences which are existing at the level of the groups and which are actually avoidable. Avoidable in the sense that if appropriate intervention is made, then the poor outcome could be addressed, and that can be converted into good health outcome. That means inequality is existing, but these are potentially avoidable, and so we refer the word health inequity as supported by Amartya Sen and other people, as we discussed in the previous class also. India is witnessing differential achievement in increasing the life expectancy at birth and controlling infant mortality, then maternal mortality, and long and short-term communicable and non-communicable morbidity among and within various states and social categories. We have been witnessing those figures. The increasing hiatus in health achievement among groups in India amidst growing medicalization and other reforms suggest prevalence of a deeper creeping malaise, that is health inequality. Now, the theoretical perspectives within sociology, like Marxist or the feminist or the subaltern theorist, they have also been talking about inequalities. But the Marxist basically try to look at inequalities from the economic determinist perspective. So for them, all inequalities are caused because of the income related inequality. And so if you look it from this perspective, then health inequality would be considered as the consequence of the income inequalities. And if you look at it from feminist perspective, then they will also talk about health inequality, but from their point of view, this is the consequence of or extension of the gender based inequalities. They often say that the males have basically dominated the medical profession, and they make use of the medical profession to maintain the discrimination or hierarchy within the gender framework. Or for that matter, if you look at it from the subaltern perspective, then of course the caste inequalities would be considered as the broader inequality, and the health inequalities are supposed to be the extension of that. However, as we discussed in the previous lecture also, health inequalities are considered as a basic form of inequality, and for many people this is more important than the income inequality, because they are instrumental as well as intrinsic value they also have. Health outcome of women, children, elderly, occupational group, persons with disability, rural people and people living in 8 empowered action group states show that their health marginalization and persistence of health inequalities. And we have seen almost all these figures in some of the previous lecture or classes. We will have a glimpse of that. But before that, Ali and Nanda talk about the health inequalities existing in India, and they have identified basically 4 forms of inequalities in Indian context. And they think that the inequalities and inequities both are disparities. So whether you talk about health inequity or inequality, both are at some level getting expressed as disparities. And what are the 4 forms of disparities identified by these people? So one is the geographic disparity. So we know that in India there are 29 states and then union territories, and we have a very vast geography, and then the states are not showing similar health related outcome. We have been seeing the performance of good number of states in the previous lectures, and we will have an overview of that in this lecture also. But the point that we are making here is this, that the diversities are existing, and these diversities are also reflecting the kind of inequalities in health outcome, or for that matter even the demographic outcome. So Ali and Nanda have given the example taking from the total fertility rate, and saying that only few states basically have achieved the replacement level of 2.1. And then they also say that issues related to infant mortality, maternal mortality, or expected life at birth, etc., these are all having differential outcome in different states. So that is a kind of geographic disparity. And what is interesting here is this, that for them the differences are largely because of the prevalence of poverty, illiteracy, and inadequate access to healthcare facilities and family welfare services. So we have seen these things, but I have included this point of view because it helps us to understand the different forms of inequality. Now, another form of inequality, as mentioned by these people, is gender disparity, and time and again we have been talking about this. So, we will not discuss anything further on this issue because we have already understood it. But what I would like to say here is this: that the adverse sex ratio of women, it also indicates the prevalence of discrimination at the level of the gender in the health outcome. And then Amartya Sen has once talked about the million missing women. So that is also indicating the adverse sex ratio, right? So all these things help us to understand that the position of women is not as good as that of men in an overall sense if we look at it in terms of health outcome also. And as the feminist thinkers say, that primarily it is because of the patriarchy, and we also at a larger level agree to this fact that patriarchy is very much prevailing in India, and that is creating a multiple times of discrimination and deprivation also. Then very important disparity identified by Ali and Nanda is related to the caste based disparity, basically the disparity among the scheduled caste and scheduled tribes. So scheduled tribes is a kind of a special inequality or deprivation, because scheduled tribe people are not as such part of the caste system. They are identified as a specific group because of the places and the kind of culture and language and lifestyle they are having. But there is a special connect in this, but very often we talk about the scheduled caste and scheduled tribes together. So there are increasing argument that the causes of poor health outcome among scheduled caste and scheduled tribes is also a reflection of the prevalence of health inequalities. And we get to know on the basis of various report and data that uh, most of the health related variables are actually performing poorly among these specific groups of people. So that indicates some kind of prevalence of health inequality also. And then the poverty related issues. So most of the data related to health outcome, if available in terms of the income group, categorically suggests that the lower income group are having high prevalence of good number of communicable disease, and they are also having high prevalence of infant mortality, child mortality, and maternal mortality. And I remember in one of the lectures earlier, we were talking about the health indicators, and that there was basically a connect with the socio-economic background of the countries, and we had seen that most of the communicable disease were actually prevailing in the countries which were having poor socio-economic development parameters. So there is a very well identifiable connection between communicable disease and the socio-economic background of people. Although COVID recently has broken some of these understanding, and because pandemic basically is beyond the uh, understanding of this socio-economic or other kinds of social determinant sort of thing. Pandemic once come, so that cut across all those aggregations kind of thing. But that is a different situation. We are not talking about the pandemic as such. We are talking about the nominal health outcome that which prevail in the day-to-day life of people as such. Then a very important question is coming, that if all these four forms of inequalities are existing within the domain of health, then why do such inequalities actually exist? And for that, basically, we need to talk about some of the more important questions which are basically related to the structure of Indian society, something that I was talking about when I was beginning this lecture also, while we were having an introduction of this lecture. Actually, there are structural inequalities, and these are prevailing almost globally. So, if we look at Indian society from that perspective, then we can identify that inequalities like gender-based inequality, caste inequality, income inequality, spatial inequality, then disparity among the states, all these are actually structured. These are there. Although there are efforts to break those barriers, but these are existing. And along with these things, there are few other important things which are actually developing. For example, the social security measures. Earlier, we were not having the social security measures. Now, in independent India, because of the formalization of the economy and the social sector, the coming into existence of the sovereign government, now we are witnessing the prevalence of social security measures. And these are the best protection that which are available to citizen at a larger level. But the question here is this, that what percentage of the population is getting benefited by the social security measures? And if we try to understand this, then we get to know that largely the social security measures are available within the organized sector or the formal sector of the economy. But what percentage of people are there in the formal sector or the organized sector? And various reports indicate that almost like 90% of the employment are basically existing in the unorganized sector in India. A few points here or there, but when 90% of the population is working in the unorganized sector, then the unorganized sector is actually not having the kind of social security measures. That means whatever benefits related to social security we are talking about, but these are not available to the people who are working in the unorganized sector. Now, nowadays, the political elites, or you should say the government basically, instead of political elite, it would be better to say the government. The government is extending the benefits of social security to the people coming from unorganized sector also. But the problem here is this, that those are not systematic or not systemic. That is why I use the word political elite. If these are not systemic, that means there is no guarantee that those benefits will continue to be enjoyed over a longer period of time. And those are actually associated with the ideology of a particular political party or ruling dispensation. So, there is problem in terms of having the social security measures. And then another very important point is something which we have been discussing in last 3, 4, 5 lectures, and that is the out-of-pocket health expenditure. There is an increasing burden of out-of-pocket health expenditure, and almost like 50% of the health expenditure is primarily the out-of-pocket health expenditure. And we have seen that the universal health coverage program is trying to minimize this burden of out-of-pocket expenditure at a larger level. And in India, we are having basically a trend that the at a larger level, the out-of-pocket expenditure is actually reducing. That means some kind of relief the people can enjoy. But that trend is emerging. And what is happening at a larger level? The larger level situation is this, that despite all provisions by the government, at least 50% of the burden of high cost of healthcare is actually experienced by people. And that in itself is a big factor for causation of some sort of economic deprivation and then health related deprivation. Because very often people are not getting the health facilities because of the constraints related to affordability. And the empirical studies do talk about these things. In this course, basically, we have not included the empirical research findings, because generally these are not part of the uh, class courses at undergrad or postgraduate level. But here and there, we have been talking about those things also. So there is a scenario in which structural inequalities are prevailing, and then situations are emerging which are of course creating new hopes, but at the same time also reflecting the problem existing at a deeper level. Now I have included here few slides that we have already discussed, but just I want to make use of those slides in the present context so that you can relate this lecture with all the previous lectures if you try to see the existence of or prevalence of health inequality in India. So, in the lecture number 44, we talked about the Empowered Action Group EAG states. There are 8 states: Rajasthan, Uttar Pradesh, Uttarakhand, Bihar, Jharkhand, Madhya Pradesh, Chhattisgarh and Odisha, which are basically showing very poor health indicators, and so they are coming under the Empowered Action Group category. And what is so problematic about these states? So here are few facts. These 8 EAG states contribute 50% of India's population, 68% of childbirth, 70% of infant death, 72% of under 5 mortality, and 80% of maternal mortality. That means good number of population related issues and basically the health related issues are concentrated in these 8 states. So this is showing the kind of disparity that we have been talking about. And these are basically based on evidences, because these are the data provided by government, and the Empowered Action Group concept was developed by the government. Then in lecture number 44, we talked about the disparities existing among the states in the context of body mass index of women, right? So you can see that all these states from Jharkhand, Bihar to Madhya Pradesh, Gujarat, Rajasthan, Chhattisgarh, Odisha, Uttar Pradesh to Sikkim and Mizoram and Kerala, they are all showing different outcome in terms of body mass index. And then further, the rural and urban gap is very much visible. So this slide is showing the disparity or inequality existing among the states, and at the same time existing between the rural and urban areas. And then similarly, we have seen all these slides in lecture number 47. Basically, we talked about the problems related with the children, and so the disparity is visible here and then even here, and this is also indicating the kind of disparity existing among states related to underweight. And then we talked about the disabled population, and of course we can see that the age group and the proportion of disability. So this is also basically emerging. and we had a discussion on this, so you can refer to this lecture number 49 also, and then lecture number 50 also, where we were talking about the occupational health, and lecture number 52, where we were talking about basically the average medical expenditure per case of hospitalization. And why I have included here, just to show you that the cost of treatment in the private hospital is much higher than the cost of treatment in the government, and then that difference is also prevailing in terms of rural and urban. That means the cost of treatment in the private is also very high, and if a kind of privatization of healthcare is happening, then that is going to increase the health inequality, because the cost or the affordability issue is a very serious issue. And here I have included some of the arguments presented by Surinder Jindal in one of his articles, and Surinder Jindal is saying that privatization leads to a steep hike in health expenditure attributable to the increased cost of medical consultations, drugs and devices, medical tests and hospitalization. That means he is categorically of the view that privatization of healthcare is going to increase the burden of people, and as of now we are already witnessing privatization of healthcare. So this is causing some kind of inequality also. So we have discussed basically all these points, that why health inequality and inequity prevail in India. Almost all the points we have discussed, right? And so we come to the last point, that is way forward. So if this problem is existing, then what could be done? And yes, the answer is we already know the answer, that basically we need to make an improvement in the universal health coverage, and then reduce the out-of-pocket expenditure, and then we need to make a special initiative for women, children, elderly, and basically have a more focus on disease control programs and then immunization program. And last but not the least, we need to increase the social security measures. If I have an opinion on this particular issue, then my opinion would be this, that the governments are working very well on all the health related indicators, but the effort basically is not that well or systematically organized in promoting the social security measures. India needs very great provision of social security at all age group level. So without having the social security provisions, it will not be possible to mitigate the inequalities in general and the health inequalities in particular. Because people do need some kind of social security, so that they can have peace of mind, and that peace of mind is very necessary for their mental health, which is inseparable part of health. So with this, I hope you got some idea about health inequality in India, and the kind of initiative that we need to take at a larger level. We, the people of India, also need to make good initiatives, so that we can make a peaceful, harmonious society where we can ensure mental health for all also, and along with that mental health, we can have health for all. So thank you very much for being with me, and we'll meet in the next lecture. Till then, take care.